Ladies and gentlemen, dear friends and colleagues, I'm very happy to be here with you, and it is a great pleasure to be a speaker at this wonderful meeting. First of all, I want to say thank you, big thank you, to all the Bansi family and their associates, and especially Emir Volodar, our dearest friend, for all his support during our collaboration. And thank you, Emir, also. And thank you, Ali, for wonderful words. So this is my topic, clinical applications of PRF in dental implantology and regenerative dentistry. But everything is about family, so let me say a few words about my family. So family dentistry is our family tradition. Everything started with my late grandfather, who founded his dental practice in 1930, where he started working as a dental technician. Then he's got a license to practice dentistry, and he was doing that for the period from 1984 until 1962. Where are we now? My father founded our private dental practice in 1990. And this is our private dental practice located in the old part of Sarajevo, which is the capital of Bosnia and Herzegovina. This is our team. My father, retired professor from the Faculty of Dental Medicine, University of Sarajevo, also a former dean of the same university, but now very active in his private practice. There is my mother, pedodontics, still working with preschool and school children. My brother, he is an oral surgery specialist, practicing general dentistry and other dentistry disciplines, especially implantology. And here is me, oral surgery specialist, recently promoted into the associated professor at Faculty of Dental Medicine, University of Sarajevo, where I work full-time and part-time in our private dental practice. 20 years ago, my father started collaboration with B&B Dental. And this wonderful collaboration lasts until now, and I hope it will only grow in the future. So let's get back to the topic. Considering my topic, the clinical applications of PRF in dental implantology and regenerative dentistry, there are 5 features that I would like to highlight. And these are wound healing processes, platelet concentrate, the modern platelet concentrate like PRF, new PRF protocols launched from 2019, especially sticky bone making, and I will show you some clinical cases where we use the B&B Dental products. By that I mean B&B Dental implants and B&B Dental bone substitutes, Novocor Plus, with a little help of PRF. So, wound healing is a complex biological process where many cellular events take part. There are 4 aspects of wound healing that are overlapping and very important in the regeneration processes, especially in humans. What are these aspects? First of all, hemostasis, then inflammation, proliferation, and maturation. As you can see from the pictures, there are numerous of cells, numerous of growth factors that play important role in these processes. So first of all, platelets. Platelets are key components that are affecting of early phases of tissue regeneration. First of all, very important during the hemostasis and fibrin clot formation. Also, they secrete important number of growth factors. Among many, I can say some, I couldn't say that some growth factor is more important than another, but let's say that we have platelet-derived growth factors, vascular endothelial growth factors, coagulation factors, cytokines, chemokines, adhesion molecules, and also angiogenic factors. All very important in the reparation and regeneration processes. So, here we are now, thinking about regenerative medicine. what happened in the past and what is happening even now. Some are trying to use some foreign materials derived from allografts, xenografts, and to incorporate them into the humans in order to promote the healing processes. I cannot say that there is no result, but there are some possible foreign body reactions to those products. And here we come to the concept of platelet concentrates. Scientist Ross and his associates first mentioned these concept of platelets and their regenerative potential in 1970. And since then, we have many platelet products. First of all, fibrin glue, which is a product made of high concentration of thrombin and fibrinogen, but very expensive to use. And now we have two products, PRP, which is platelet-rich plasma, and also platelet-rich in growth factors. But what we can say about PRP, the process of making PRP requires an anticoagulant added in the tube where the blood is taken, collected, and a double centrifugation process. Then we have the PRGF, which is platelet-rich in growth factors, also a platelet concentrate that have a growth factors, but here we have one more time an anticoagulant, which is sodium citrate, and after the centrifugation process is done, the PRGF is taken from the tube and mixed with calcium chloride in order to get a coagulation, in order to get a gel that could be applied on the patient. And finally, the easiest product that can be made chairside, easy to make by clinicians, is a PRF. No anticoagulant at all, no any material that is of foreign origin. This preparation is very simple. It requires only one single centrifugation. So what are the differences? What are the limitations of PRP on the one side and the platelet-rich fibrin on the other side? First of all, as I already said, in the PRP, there is always an anticoagulant, so there are possibility of allergic reaction. The centrifugation process is more complicated. It's two centrifugations. And then 90% of growth factors are releasing in the first hour. Let's say the characteristics, the advantages of the PRF. Blood collection is always without anticoagulant, so there is no possibility of allergic reactions. The protocol of preparation is very simple. Stimulation of wound healing is for significant amount of time, which means slow release of growth factors for the period of 1 to 4 weeks. And what is that is so important in the PRF? First of all, these are cells. Among cells, there are platelets. Platelets rich in growth factors, releasing growth factors. Also the leukocytes. Also very important cells in inflammatory phase of wound healing. So that is important component in the PRF. And red body cells. What is the fibrin matrix? That's the main component that we use, and that is practically the reservoir or the growth factors that are released by the platelets and the leukocytes. And what are the growth factors? Transforming growth factor beta, platelet-derived growth factor, vascular growth factor, and many, many more. What is the role of growth factors? Most of them have many wonderful roles, and among those roles, I can highlight their angiogenic activity, the activity to promote new blood vessel formation, and that is the key point in the tissue regeneration. So, this is the Shukron's concept of PRF, actually the equipment that we need to produce the PRF products. First of all, this is the centrifuge. In this particular case, this is a duo quattro centrifuge, but it doesn't necessarily be this kind of centrifuge. Here we have 3 types of tubes, all vacuum tubes. First of all, it's a red tube for advanced or APRF, then IPRF, the orange tube intended for sticky bone, large membranes. So this is the orange tube. And the last one launched this year, the newest one, is green tube, especially for large membranes and sticky bone making. Then we need a tourniquet, blood collectors. This is the specially PRF box for making PRF membranes and plugs, and a set of 7 PRF instruments. So, what is the advantage of a new duo quattro centrifuge over the older versions of centrifuge? The only advantage is that this centrifuge has 6 memorized protocols. So these are the protocols. When I'm making a PRF, sometimes I act like a chef in the kitchen. So you follow the recipe and you will get a product. So the first position is APRF plus. So you see here that this protocol means 1300 rounds per minute, and the spinning time is 8 minutes, intended for PRF membranes and plugs. There are 3 IPRF protocols. First 2 are intended for injection in soft tissue, injection in bone graft, and formation of sticky bone. The purple IPRF plus protocol is for facial aesthetics and for orthopedics. APRF liquid is an interesting protocol, especially intended for sticky bone and large PRF membranes. And the last one is actually the oldest, PRF-L. L is abbreviation for leukocytes protocol, also a very good protocol for making PRF membranes and plugs. So this is how everything goes in practice. First of all, first phase is venipuncture. Venipuncture is when we collect blood using the vacuum tubes. This phase must be quick as possible because of the speed of collecting blood and transferring the full 10 milliliter tubes into the centrifuge depends the quality of our final products, PRF membranes and PRF plugs. So we draw the blood, choose the adequate protocol that we want to use on the centrifuge. We put the tubes into the centrifuge, having in mind that every tube must have an opposite tube for the balance and for equilibration, the centrifugation forces, and to prevent vibrations. Then, after the centrifugation process is done, the lid of the centrifuge opens automatically, and we must take out the tubes and put the tubes into the sterile tube holder. Open each tube and leave it that way for about 4 to 8 minutes for the clots to maturate. After that, the clot is taken out with a surgical forceps. The excess of red blood clot is peeled out or cut from the rest of the fibrin clot, and then the clots are put into the PRF mesh, press with the lid in order to get membranes, or put in the white cylinder, press with a piston in order to get PRF plug. And that's basically the whole process. So what is new in the PRF protocols? So new is that there is a new protocol, very simplified, that means 1300 rounds per minute for 14 minutes. You see 3 times this protocol, which means that this protocol is capable of making membranes and plugs by collecting blood into the red tube, and also making large membranes and sticky bone by collecting the blood into the S tube. What that means? It means that we can draw the blood first in red tubes, last in green tubes, arrange the tubes into the centrifuge and set this protocol. And here we are having two products with only one slow centrifugation protocol, which means a better growth factors release. In a case, if you don't have the green tube, you can also use the orange tube and follow the same protocol to get same products, which means sticky bone and also large membranes. So what are the clinical use of PRF? From my colleagues, you can hear some indications of using PRF in socket shield techniques. So there are many. I couldn't wrote all the indications on one slide, but there are some, like filling the defects after apicectomies and cystectomies, then extraction, socket augmentation also, sinus elevation procedure, implantology, of course, GBR procedure, and what is also very important and what is new in treating the medicament-related osteonecrosis of jaws. This is the condition in patients who are receiving parenteral bisphosphonates, mostly patients suffering from breast cancer, prostate cancer, and so on. So the point of my lecture is going to be also on how we continue to use B&B Dental products, dental implants, and also a bone substitute, B&B Dental, Novocor Plus with PRF. I'm going to present you 7 cases, very briefly, where you will see some of these indications, and the last case will be presented over a video. So the first case is immediate placement of implant into fresh extraction socket. How we did it? So this was the patient who came to us with the indication for extraction of tooth 46. The plan was to extract the tooth 46 as traumatically as possible to leave the interradicular septum intact. So we did it, used that septum for B&B Dental implant insertion. Then we had to fill those gaps with something, and that something was, of course, combination of PRF and membranes. This is the most, I can say, the simplest protocol that I can tell you about. So the process is to draw the blood and to start the PRF plus protocol, which is the protocol for membranes. When we got a membrane, one membrane is cut into pieces, mixed with Novocor, with a little of PRF exudate, which is very rich in fibronectin and vitronectin. So this is that mixture that is already sticky, easy to apply. So we fill all the gaps with that mixture, compact it with a bone compactor, which is one of the PRF instruments, and cover everything with PRF membranes. After the mucoperiosteal flap is released, we always put apical matrix sutures to avoid the tension, because according to scientist Mamoto rule, where there is a tension or pressure, there is a resorption. So this is the way how to avoid that. And here we can see the final X-ray immediately after implant insertion and after augmentation with this mixture. Final prosthetic restoration was with a metal ceramic screw retained crown. Case number 2 is implant placement after extraction site augmentation with sticky bone. So this was the delayed implant placement. You can see this situation with a patient with severely periodontally involved teeth 47 and 48 with the exposed distal root of tooth 46. So what we decided to do is to do the extraction of tooth 47 and 48 in one visit, to make the sticky bone, this time following the protocol APRF plus. APRF plus is protocol, APRF liquid, sorry, is a protocol with centrifuge setting on 1300 rounds per minute for 5 minutes, and then additional 3 minutes for making a membrane. So the defect was filled with a sticky bone and covered with PRF membranes, and this is how everything looks clinically 12 months after augmentation. The implant was placed. I can say that clinically it wasn't possible to differ the recipient bone from the augmented bone. We didn't have to wait too long, but the patient wasn't in Bosnia, so he came after 11 months, so this is why we do the implant insertion after 11 months. So this is the OPG of the same patient just after 11 months. So you can see much better situation with the distal root of tooth 46 and the obvious vertical augmentation of the remaining bone. So the wound was also primary closed, and here is the X-ray immediately after implant placement. So this patient is still in procedure to get his final prosthetic restoration. Case number 3 is severe tooth extraction with a buccal bone deficiency and implant placement and use of sticky bone and PRF membranes. So this is the situation. This particular patient underwent a severe tooth extraction where his buccal bone was, I can say, completely lost. He came to us after a few months insisting in having implant. So we did the CBCT planning first. As you can see on the CBCT, the buccal threads of implants are going to be exposed, which was clinically proved after implant insertion. What was the protocol this time? This time we used the newest protocol, which means 1300 rounds per minute for 14 minutes, and make the strong and dense sticky bone. Why I'm so constantly talking about strong sticky bone? Why is sticky bone so important? It is important because we used to mix Novocor with few drops of saline, and we got a mixture that wasn't stable enough to stay on the surface where we placed the mixture. This time, this is very elastic. All bone particles are just gathered together in that fibrin matrix, I can say that. So we do the perforation with round burr on the recipient bone. The sticky bone was placed and shaped. We can shape it like we want. Then everything was covered with the PRF membranes, and the wound is primarily sutured. So this is also one of the newest patients, because remember, this protocol is launched in 2019. Case number 4 is a situation where, with the placement of 2 Duravit implants and treatment of intrabony pockets, also by sticky bone and PRF membranes. So here we have a patient with a severe bone loss around teeth 16 and 17, but he insisted on fixed prosthetic restoration. So here's the plan. We decided to do implant placement into the remaining bone. First, the 2 teeth were extracted before that. Then it was done the periodontal surgery around the adjacent tooth with curettage and root polishing. Now you can see in this picture there is a buccal bone depression that we also wanted to treat. The solution was once again a sticky bone. Now you can see how the sticky bone is really sticky. It's not moving. It's very easy to work with. So all the gaps between those teeth in the pockets were filled with a sticky bone, together with the buccal bone depression that was covered. Everything was covered completely with PRF membranes that are also very easy to handle. They just stick to the sticky bone. Flap was also released, sutured, and here you can also see here the apical matrix suture that are very important to avoid tension. And here is the final OPG immediately after implant placement. So case number 5 is severe bone resorption in the upper jaw, and also with deep intrabony pocket treatment with sticky bone and the PRF. So here on the OPG, you can see the extremely horizontal resorption in patient upper jaw, and he also insisted on fixed prosthetics. So we must do something with his bone and his remaining teeth. So we did the extraction of this teeth over here, do the periodontal surgery, root polishing, and prepare the site for the sticky bone. Here you can see a good, strong, and dense sticky bone, an example how you can cut the sticky bone into pieces and to adjust it everywhere you want to place it. So it's very, very easy to work with. One small sticky bone on the operation site, placed, the pockets filled, PRF membranes over the sticky bone, and final prosthetic restoration for this patient. Case number 6 is deep intrabony pockets into the upper and lower jaw, also treated with sticky bone and PRF. So here we have also patient with all his teeth basically, but periodontally involved deep pockets. So we also did the periodontal surgery, curettage, root polishing. And this is what we actually get in the first place when we are making sticky bones. So this is that protocol APRF liquid where the supernatant from the tube is mixed with Novocor Plus to get this gel phase. And then you can shape it to get the sticky bone in every shape that you want to use it. You will it will be much clearer when you see my last video that I prepared for you. Additional 3 minutes of centrifugation after the PRF membranes. And that's when we are combining APRF plus protocol with a protocol of APRF liquid. So here is one more time, sticky bone in action in the upper jaw. PRF membranes covering all that. And of course, sutures with apical matrix sutures to avoid the tension. Same situation in the same patient in the lower jaw. This was done in the next visit, not in the same. Periodontal surgery, intrabony pockets treatment. Once again, sticky bone. And then PRF membranes. And of course, sutures and his final prosthetic restoration. Case number 7 is tooth extraction, indication for tooth extraction with the large radicular cyst, which was removed, and just a case how we augmented that defect with Novocor Plus and PRF membranes. So this is the tooth 17 and the cyst around the apex. So the therapy was to extract the teeth and to fill it with the sticky bone. So this is enucleated cyst, of course, first. So this is the extraction wound. Relaxed mucoperiosteal flap. One more time, one PRF was cut into pieces and mixed with Novocor with the fibrin PRF exudate. In this situation, we decided also to make a PRF plug. So this is the PRF plug. You can make it when you put PRF cloth into this white cylinder and press with the piston. So the protocol was to place the PRF plug into the apical part of extraction wound, and then mixture of Novocor and PRF membrane, and after that to cover everything with PRF membranes on the top. And the primary wound closure. So this is the OPG immediately after augmentation. The last case that I'm going to show you, it's a video. Just for the introduction, this is a situation with large radiolucency around teeth 31 and 41. The patient had a apicectomy a few years ago. He came with the same problem. This time he didn't want to do the endodontic retreatment, and he was also a cousin of my best friend. So they asked me to do something, and I just decided to film the whole situation just to more clearly present what I'm doing. And also that I want to highlight yet this time, exclusively for the first time, I did the sticky bone with my own protocol, let's say modification of protocol, by using Becton Dickinson tubes, which are very affordable tubes. So let's see it together. end, there are some conclusions. So you can see that PRF is having multiple indications in oral surgery. It can be used alone or in combination with other biomaterials such as Novocor Plus. And also I can't wait to work with Novobone, a new B&B Dental product. PRF is completely autologous product derived from patient's own blood, so there are no possible allergic reactions. And what our patients told us, they have no pain after oral surgical interventions. That would be all. Thank you for your attention and greetings from Sarajevo.
Thank you. Thank you for a very nice presentation. It's very interesting. Huh?
Thank you.
Thank you very much.
Thank you, Claudio. Thank you.
Where is the brother? This is for you. Huh?
Thank you very much.
For you.
It's ours.
Thank you very much, Evan. Thank you, family.
Thank you. Thank you.
Thank you
It was a pleasure.
The family. Okay.
So it was a great pleasure to be here. Thank you one more time.
And this is a present for you. Professor Sulejmanagić is one of the very old user of this.